Hopefully we're recording right now. So we know we're getting it added. Sure, it's gonna pass. All right. So I want to welcome everyone today to the Medical Cannabis Policy Advisory Board meeting on February 18th, 2025 here in Salt Lake City. We do have a mixed board attending, both virtual and in person. And we'll kind of get started through here. So just read through our welcome script. So it says, I think my pages, oh, there we go. So this meeting is being held virtually and in person and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah's open meeting law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. A rough draft copy of the unapproved written minutes will be posted to the Public Notice website within 30 days of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. Every proposed agenda item must have a 1-page summary of the topic submitted to mcpab@utah.gov, no later than 7 days prior to the board meeting. Board members will present the 1-page summary during board meetings and board members will discuss the summary. If no written summary is provided to board staff, the relevant agenda item will be removed from the agenda. Only items that have been submitted in writing in advance of board meeting will be allowed during discussion by the board chair, including presentations from the public. Board members will then request additional presentation and memorandums on those agenda items from relevant bodies to be presented at the next board meeting. Those presentations and memos will also need to be submitted to mcpab@utah.gov 7 days prior to the board meeting. In making public comments will be limited to 2 minutes per person. If you want more time, you must request it from the chair. The chair may accept or reject requests for additional time. A public comment period is not guaranteed every meeting. The chair has the authority to create or remove public comment period from the agenda or during the meeting. You can look over public comment guidelines that are posted on the Utah Public Notice website. Please state your name and your affiliation when making a public comment so it can be reflected in the meeting minutes. Only comments made on items listed on the agenda will be considered. If you have a comment about an item not listed on the agenda, please email them to mcpab@utah.gov. If you're on Zoom and like to make a public comment, when it is public comment time, please, the chat will be disabled during the meeting. When the chair indicates it is time for public comment, you will use the raise hand icon on Zoom to indicate that you would like to make a comment. When you are called on, you will be taken off mute. Take 2 minutes to make your comment. Sign in on the public comment sign-in sheet with your name and indicate what agenda item you want to make comment on. The chair will indicate when it is time for public comment period. The board chair will call on you when it is your turn and you will come to the public comment table. Take 2 minutes to make your comment. As a reminder, if you're in person, please do not speak when others are presenting. Our mics are very sensitive and those attending over Zoom cannot hear when there is more than one person talking at a time. Side conversations and comments from the public during this board meeting are prohibited. Please use a voice that is louder than your typical one when speaking, commenting, or presenting. When you speak, please lean towards the table as if there were a microphone. For additional information, to make a suggestion for agenda items, or to contact board members or staff, send an email to mcpab@utah.gov. With that, we will move on to the second agenda item, which will be the approval of the January 2025 minutes. If anyone has anything to add, everyone get a chance to look over it.
I move to approve the January 2025 minutes.
I would second that.
We do have a second. All those in favor say aye.
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 Thank you, Chris. Let's see, moving on to administrative business. So we do have a couple items on administrative business. So there is one handout that was provided for today's meeting called Medical Cannabis Policy Advisory Board Conflict of Interest Policy and Disclosure Statement. One of the things that has come up to me in discussions is whether or not, as policy advisory board members, should we be voting or be present for meetings when it can be a perceived conflict. I think one of the things that to kind of answer this is we all filled out a conflict of interest disclosure and statement. And as a reminder, if any time that you feel that, hey, you, in your work life, personal life, whatever, something changes to where you could foresee it could be a conflict, you do need to let the board know. So that way we can get this corrected. Just that way, it's our way of just saying, you know, we recognize there could potentially be a conflict. There's 9 of us that all represent different facets of the industry. And we're okay with your participation in meeting, discussion, and votes. So, any questions on any of that?
On the form itself, if we, obviously,
need to fill that out.
if you're, if the entity
when you first get it.
changes, right, we need to make sure to
Yes.
update that, but
Yep.
should we be updating any changes, for instance, like a change in address, because it says I reside at? So do I just fill this form out again and turn it in?
I think this is just an example form, or can we use this as a disclosure?
I added this part here at the top of the context, but
Okay.
if you want
Okay.
an updated copy, I can send it out. Type in it.
I'm just wondering, for Jady's question, is it okay if he just uses this if he has to make some changes?
If you like, we can photocopy it.
Because I mean, there'll probably
problem.
there'll be other changes, you know,
Yeah.
when, you know, if the deal that we're in closes,
Yeah.
right, obviously,
Yeah.
disclose that, but my address has changed, if that's not a big deal, I can wait until we go further along, but you guys just tell me, I just want to make sure I'm accurately disclosing my information, because I'd hate to be removed from the board because I didn't change my address. So just let me know how I should handle it.
Is it the same city? Nope. I was thinking
I'm
it
now
was just the
now-
city
now
and
Davis
state.
County.
Hey,
Suffolk
look
County.
at that. Hire
Tell
the
you,
civil
my ballot-
attorneys
My
too. yeah.
ballot looked very different in Davis County and in Suffolk County, that's all I can tell you.
So, any questions or anything from the board?
No, so just so long as we've disclosed our conflicts, the board's position is that we're allowed to participate in meetings and vote on things.
Yeah.
So for instance, even if something were to impact the policy around medical cannabis pharmacies, and I obviously have a position with a medical cannabis pharmacy, as long as I've disclosed that conflict, I'm allowed to participate in the decision.
Yeah,
making.
based off our bylaws, we have accepted that as perfectly fine. Had we not modified our bylaws, the state does have rules in place that prevent people who have conflicts from participating in discussions, voting. They can either remove themselves from the room during the entire conversation and vote, stay.
But we've
yeah,
determined that as long as we disclose it,
Yes,
that's sufficient.
yes. So yeah, if there is anything to update, please get that a copy of this. Maybe we'll send an additional copy.
Yeah.
It might be nice to send
Yeah.
the original ones that we did, just to make sure that we have.
If you'd like to see them, I can send them
Yeah.
to each of you one-on-one, so you can see if any updates are needed.
We have recently had to fill these out for other committees. Even when we filled them out previously, they wanted it
An
updated,
updated one.
even if it's the same,
Okay.
so just.
Is there a standard practice on how often they fill this out? I don't know, Rich or anyone
Update ours yearly.
yearly?
It's employees, we.
Yeah.
If anything changes, but then yearly.
Annually, yeah.
Well, and maybe with us as our board is, our year is in July. Maybe that's something we can just tag for all
Each
future,
July
agenda- each
meeting.
July meeting.
Yep.
As we get new board members or
Sure.
we go through another year, we can just go through this process again.
Yeah,
So,
good idea.
Or as our positions on the
Okay.
board change.
yes, you just a different seat.
Matt, could I make
So,
a quick
yes,
comment?
yeah.
One idea Shannon was just suggesting is that we create a Google folder where we have this form and other forms and other information that is just general to board membership.
Okay.
And
Fantastic.
Abby could create that Google folder and then. Right, but I don't know if board members have access to that.
No, but if anyone would
Yeah.
like to see that,
Yeah.
absolutely, I think you have that. ready to
Right.
go.
So if you had a change, you wouldn't have to contact Abby to find it. You could
Great.
have
Yeah.
that Google folder and access
Right.
it on your own time.
Yeah, perfect. No, I think that'd be a good idea.
Yeah,
So that way we can all have access to it going forward.
right.
But yeah. Yeah, just a good reminder. I mean, again, I understand on the board side, the conflicts, but we know that we've given ourselves exceptions to our bylaws. So if anyone asks you why are they participating or why is it this way, it really just answers all those questions. Right, if there isn't any further discussion on that, we will move on to our the DHHS and UDAF updates, and we'll start with Mr. Oakland.
Yeah, well, and I always start with just some general statistics of the program where we're at as of today with active medical cannabis cards. Is we've got 95,000 852 active medical cannabis cards as of today. And I just did a little search of where we are at the end of last month. And 55% of active medical cannabis card holders registered with DHHS in January made at least one purchase of medical cannabis in January. So I know that's a stat the board was taking a look at earlier, and so that's why I share it today. And then 964 qualified medical providers as of today. That's 4 more than last month. And then 84 pharmacy medical providers, or pharmacists working at different medical cannabis pharmacies. That's 2 more than the previous month. So that's where we sit for some of those. If there's ever any stats as board members you would like to be updated on in the future every month, you can reach out to me and let me know, or let Trevor know. But there's a comprehensive report that is posted monthly on our website that I know the industry relies on and appreciates. And that also has data from the Utah Department of Agriculture and Food that we incorporate in that on our website. Okay. And then also, by way of information, there were some Center for Medical Cannabis fee reductions that lawmakers recommended. That the Social Services Appropriations Subcommittee, they did approve a motion to recommend that lawmakers that there be 2 fees that be reduced. The first is the medical cannabis card application fee that is being recommended to be reduced from $15 to $8. And then the uniform transaction fee that is being recommended to be reduced from $3 to $1.50. And we won't know whether that's finalized until like the last days of the legislative session, until early March. But that at least gives you a heads up that we could see that change happen. And the subcommittee did recommend that. And then medical provider training, or the contractor that we contract with, Dr. Matt McKiff, who's a physician, he just accepted an invitation to present at the Utah Nurse Practitioner Pharmacology Conference on May 16th. And that's being held at the Sheraton in Park City. So if there's any medical providers that are interested in benefiting from that, they're able to attend that conference. And then that is in addition to the presentation that I think I've already told you about, but he's presenting to the Ogden Medical Surgical Society on May 15th. So both of those are coming up in May. And it's always good when we get on those schedules to present at those conferences to medical providers. So we're looking forward to that. Also 2 enhancements to the electronic verification system. And the EVS, or electronic verification system. This is the system that pharmacy employees and medical clinics are in every day as they recommend medical cannabis or assist a patient with their recommendation after they've been issued a card from pharmacy. And just some enhancements we've made as employees at medical cannabis pharmacies now have an enhanced ability to search in EVS for an application submitted by a limited medical provider. And so we were able to just make that enhanced ability to search. So we're excited about that. And then also employees at medical clinics now have an enhanced ability to manage patients in the EVS. And that was per recommendation of the medical clinics. They just gave us some suggestions on how to search that information a little easier, and we were able to incorporate that, and that is live in the EVS now. So we're pleased that we were able to enhance those functions, and that the users that are in it every day are able to get what they need quicker. So that's all. Are there any questions about items that I shared?
Thank you, Mr. Elborn. We will proceed to go to Dr. Forsyth. Online. Is he online?
Yeah, I'm here. Can you hear me? Can you guys hear me?
Yes, we can.
Oh, okay, great. Um, Not a whole lot new today. Obviously in the middle of session, so staying pretty busy with that. I'm sure we'll have a lot more to talk about next month based on some of the legislative changes that have happened. But let's see. So the closed door pharmacy rule will go into effect on the 21st of this month, and we'll be watching for any changes to the rules or to the statute that may affect that code, but we're not anticipating any in that one. As far as the ICS goes, we're still having difficulty with the data transformation, but we're working on some solutions with ASD as well as our internal technology services over at DTS. So we should have some updates for the ICS program at the next meeting. It will be a bit more impactful than what I can share today. And that's it.
Thank you, Brandon. Question on ICS. I mean, is it just the data migration that's the big holdup? If we were just to start from scratch,
That's one of the options that we're considering at this point. The problem is we can't really start from scratch because there's existing inventory.
Yeah.
And so it is a possibility that we just try to grab the existing inventory somehow and all the test results, but it's more complicated than just starting from scratch, unfortunately, no matter what we do.
All right. We'll wait for your update.
Yeah.
Not any questions from anyone of the board members? I will go ahead and move on. So on the agenda, we do have written HB 203. We will discuss it shortly, but it will probably actually more bleed into probably SB 64, which wasn't written. HB 203 did go to a committee last Thursday.
Senate House and
Yes.
Health.
Yeah, the Senate Health and Human Services, and essentially it was put on hold. Meaning that it's now up to the discretion of either the chair of the committee or the sponsor of the bill to try and push it to go to committee again. But the way things are looking, it's looking like it will more than likely just be held up and won't go anywhere. And it's probably true in that is that in SB 64, there were several points that were added in a substitute bill today from items within HB 203. So in talking through SB 64, just so the board is aware, some of the changes that were added into this one that were from HB 203 is and something that as a board we discussed last year was the cap on pharmacy licenses. Thank you for the correction. Cap on processing licenses. And they're doing that cap at 18. So that was added into that. I think
It's probably easier to say what didn't make it over than what made it.
I think that's
Is the two main things that did not make it from HB 203 and
Were the
SB 64,
ombudsman
pharmacy licensing
and
and
ombudsman.
the ombudsman. For the most part, everything
Everything
else
else.
did. I think there's a couple of things that maybe didn't. I don't think the irradiation piece
Yeah, radiation's
made it
not in
over,
there.
but for the most part, those were the two big things that didn't make it from HB 203 into SB 64.
And SB 64 already had the letter of concern, the time frame, everything already within it. So it wasn't necessarily that took it from HB 203. There probably would have been combined anyways. Yeah, I don't think there's anything else added in there from what we had discussed last when we did discuss SB 64. I think that's pretty much it. I mean, unless. So we should fly pretty quick in today's meeting. So that was a very large bill that actually is held up. So it may change. I mean, they still have time. They might come to an agreement on something, but more than likely it will probably stay pretty flat. So with that, we'll just go right into HB 357, which you do have a bill summary on. Did you add the amendment that was
The amendment should be
in there?
printed
Yeah,
out and
yeah.
everything.
So you do have that in there. So HB 357. So this is a bill by Representative Ward and on the floors for the House, and then the Senate will be Senator Escamilla. This bill really just changes a lot with when it comes to who can issue cards. Essentially, it's anyone with a controlled substance license. So it does add DPNs, I believe is what it is.
That's actually
Oh, is
incorrect.
it?
It doesn't change the providers, but instead it repeals QMP and LMP.
Oh,
But
okay.
it's still physicians, podiatrists, PAs, and APRNs.
Okay,
That's who would be considered a recommending.
recommending.
Correct.
Okay, yeah. All right. Well, then, thank you for clarification. They did discuss today the continuing education for medical providers will be removed.
Well, and one thing I wanted to say about that is, to me, there's clearly an opportunity at pharmacy school, medical school, a lot of these other places to interject this into the curriculum. I get that they want them to have 4 hours of continuing education, but you even heard the bill sponsor say today that he himself, I'm not passing my opinion on it, say that he doesn't think that it has, merit to it. So it might be something that we as a board, I don't know if we can have any impact on it, but clearly teaching it at the source, I think would be much more helpful than saying you should do 4 hours of continuing education every couple of years. While I think an important CME credit, just like when I was in private practice as a lawyer, not all of them were, specific to me. And I probably needed a lot more than an hour, than we usually got in those courses, to consider myself, qualified to work in that area. But I just would like to see it taught more broadly. And when we went to the symposium, the table we sat at, we did the
Mhm.
breakout groups, it was pretty clear that not even the symposium itself was being, megaphoned out to folks on, on campus,
Yeah.
to even attend something like that. So clearly, I doubt it's making its way into those schools. And I really think, we all believe cannabis is a medicine. I know that there's a debate right now, it seems like, as to whether that's true. But if we are going to treat it as a medicine, it would seem like it has an absolute place in a medical school. And that's the thing this morning that just made me just wonder, like, well, yeah, I get it, CME credits are important, but I mean, Michelle McComber from UMA said none of this is being taught, in medical school. How do we expect people to be prepared to recommend, this as a medicine if they're not even learning about, the basics of it in medical school? So
I agree wholeheartedly.
my soapbox for the day,
Yeah.
I guess.
Yeah, well, and I took that discussion this morning in the bill was, I understand them removing the continuing education because again, like all medications, the doctors, if they're gonna be doing it, they hope that they're using best practices and researching and understanding, and not just prescribing it without understanding it. And so I get to there. I think there's just the cost thing, and that's really what I think what they're trying to do is free up QMPs from any financial burden or time burden
Yeah, remove the barriers to
to
entry.
have them try to prescribe medical cannabis.
I will add though, as someone who serves as an educator in the College of Pharmacy where we do cover medical cannabis. I can't speak for the other curricula on campus, but that's something that is decided on a college or school basis, school by school basis. And it's really up to their curriculum committees. And without institutional instruction to cover it, it will
Right.
probably continue to be so.
Yeah.
But I also will add that I think that I agree wholeheartedly that as a medicine, this should be taught as a medicine. However, I think continuing education serves an additional purpose. I think like any medicine, there are updates, there are new products, there are new forms, there are things that can be learned on an ongoing basis that are subject to continuing education and should be provided as such.
Absolutely. And I think that's where the conversation kind of ultimately landed today to say like, hey, you could still take these courses, you know what I mean, and apply it towards your normal CME. I mean, I would imagine most providers similar to how I was. Yeah, there were some we took just to fulfill the requirements. But if I saw something that was interesting to my practice, I was always sure to make sure to take those. So
Mhm.
I hope they'll continue to offer them, and I hope they'll get to be more kind of less of like cannabis 101 over time and
Mhm.
more of cannabis 201 and 301 and 401, type of stuff, to where they can get that more kind of in-depth knowledge, because as a new provider, it's probably very illuminating to learn, the A's and the B's and the C's of it. But I think eventually, once you're a recommending provider and doing it, on a more regular basis, you probably want to go a little bit deeper. So I think they were basically saying, yeah, people will probably still take these courses, as part of their normal CME. They just didn't want to require it. And also I heard them talking about whether there's any other like condition for which they require, or any other medicine they specifically require them to take CME for. So that's kind of where they landed. I don't think anyone was saying they weren't important. I think they were just saying that we should just roll it kind of into the general ball of CME. So at least that's where it went. That statement was as of the end of the committee this morning.
I think it's as far as for the industry as a whole for patients. I mean, obviously, the more limited barriers there are, hopefully the costs go down. And we know just from all the studies that Board of Health has done, I mean, the cost of getting a card has typically been the highest turning point on why someone cancels. Does not renew their medical card. So finishing up on here, we'll read through the amendment as well, is there's a large portion on here that talks about targeted marketing and advertising, as well as recommending medical providers cannot receive any financial benefit from a production establishment. So a pharmacy grower processor to issue cards.
And that was already in the law.
Yeah. So they're just. And let's see, then the last thing with the amendment is packaging change, or well, warning changes. So this is one, right, as far as being in the industry as a processor, this is one talking point. It is quite a frustration is we get additional warning language added on our limited size of real estate we have when it comes to packaging. So if you see in the amendment that the line that's going to be added is talking about cannabis use by pregnant or breastfeeding women may result in fetal injury, preterm birth, or developmental problems for the child. So the question I do have is, has this ever come up to the Center for Medical Cannabis Research or the review board? Do you know, Misty?
What specifically? There's a lot of,
the cannabis use by pregnant or breastfeeding women.
it's an active area of research, yeah.
Is it?
Yeah,
Yeah.
yeah, it's covered in the suggested use guideline
Yeah.
document.
So just additional space. I mean, it's not a big deal. My company specifically, we were in the middle of reordering a lot of our bags. We put that on pause just so we can get the language added to this. Because there's nothing like ordering several $100,000 worth of packaging to have to then change it by the end of the year.
Right.
So.
And to get to our previous conversation, this is another reason why continuing education is absolutely necessary, because of all these continuous changes in the recommendations and guidelines associated with medical cannabis. And I personally find it a little bit disturbing that there could be potentially healthcare providers who, if this is enacted, could become a recommending physician and not have been taught about it in their education as a medical or professional student. So just want to go on the record as saying that, and I think the curriculums need to change to adopt it into their curricula so that we don't have that potentially happening in our state.
There is a delayed implementation of January 1, 2026 on the label, so
Yeah.
that gives processors time to respond. But still, yeah,
Well,
it sounds like in your case, you're purchasing labels far in advance.
we lucked out that we're just started the process last week.
Yeah.
Had we been 2 weeks before, it had already been printed, so. But that's okay.
I get the need for that, but I think on the alternative that maybe patients are using the black market and they don't have a medical provider even watching over them at all. And I think maybe this would be the alternative to that. So at least they're getting medical care. So yeah, the doctor might not have an understanding of how cannabis works, but at least they're watching their systems. Whereas
I agree.
if they don't have a card and they're buying off the black market, it would change things a little bit.
And that's unfortunate, but I would also want my medical care providers to be aware of what to look for. Should I be taken into an emergency room or taken into other emergent situation? I would want my physician or other healthcare provider to at least have an understanding of the interactions, the metabolism, and other special considerations.
Yeah, and I think that's underscores the importance of the pharmacist, right?
Yes.
That interacts with these patients on a more regular basis.
Absolutely.
Has the opportunity to do so. But yeah, I couldn't agree with you more. To hear that it may be being taught universally at this point. I mean, California passed medical cannabis use back in 1996, right? We're a lot of years on from them. So to know that it's not a regular part of the curriculum yet, I guess surprises me and doesn't surprise me all at the, the same time, but it does underscore, in my opinion, the importance of the pharmacist's role, right? To the extent
that's
the
the-
provider is not kind of hip to everything.
Yes.
You do have people that are doing it every single day who, who are, and I think the hope is, right, they want to push away from these clinics. And let's be honest, these clinics are what have been driving patient growth into the
Mhm.
program.
Mhm.
Their willingness to meet patients where they're at, provide them with a more cost-effective option than a lot of other providers have been willing to do. So I know they get a bad rap a lot of the time,
Mm.
but I think this is an attempt to try to push it to a more, I don't want to say normal because I don't think that's the right word, but a more traditional, I guess, recommending model. But I agree with you that if you don't know what you're recommending, you probably shouldn't be recommending it. And to the credit of the people, the folks that work with these clinics and the QMPs who are a part of it, they generally seem to have had, a better understanding. But I think that's generally what they're hoping to do over the, the long term. And I'm hopeful it's successful. I mean, the LMP program, I hope is not the kind of blueprint for it, because the LMP program has been wildly unsuccessful, despite, the attempt to design it in a way that would be. So I'm hopeful this will have a better success rate. And there's also an important detail that's in the bill about, telemedicine. We definitely were pushing for broader expansions on telemedicine, but it will allow kind of a continuing care model for telemedicine, right? So it should hopefully encourage patients to be going to their primary care providers, if they're hoping for a better telemedicine option, for an initial recommendation. But a lot of it too is still just, it's the stigma. So I figure if we start at the root of things a little bit better, maybe we can get there. So I couldn't agree with you there.
Yeah, I definitely agree with the new providers who are being trained. I also, again, will reemphasize the importance of continuing education for the established controlled substance holders who will now potentially be providers. If this is approved and moves forward, because if you graduated 30 years ago, you would have heard nothing about medical cannabis during your education, guaranteed.
Do you know, I mean, one of the things I hear continually and heard today in the committee meetings by Representative Ward, and I've heard in other meetings that we've had, is that the training, the 4 hours that is being trained, is not, I mean, it's not pro cannabis. I would say it probably leans heavier toward don't use cannabis as far as what the discussion is, rather than just being kind of down the middle of here's an education. I mean, how do we go about, how is that curriculum selected by the state as this is one that's approved for a CME?
Yeah, I can answer that. Companies come to us about it. We haven't gone to them. They come to us and say, yeah, we'd like to provide this. When we set up the program, we felt like rather than creating our own government taking over and creating curriculum, that it made sense to allow the private market to offer some options. So Intermountain, University of Utah, both stepped up. And then two companies that aren't related to government or the health system inside Utah, Answer Page and Marijuana 411, they stepped up. And so there's 4 options out there, and we set some criteria in the rule that states, hey, at a minimum, the course must cover these topics. And so we feel like that the rule covers the topics sufficiently, but if ever board members have suggestions for topics they feel like that should be required to be covered, we're happy to consider those requests over time. We've made some little tweaks to the content requirements. But if anyone has like an input about a specific phrase or slide or just something that was said or shared during a course, that would be the most helpful for us to respond to and address about the content of the course. If someone's feeling like it's biased or something like that. That is one of the reasons why the advisory board exists, is to give us input. And we do have control over the content of the coursework. Now, regardless of what happens with this bill, assuming let's assume it passes. We still are required to offer courses on our website. So we would hope that the providers are still willing to offer these courses online. And so we would still expect that the board would give us input on content that they feel should change or stay the same about the courses that we offer. Also, if the board feels strongly that the division should take action to have a course that we offer as a department only, and that it should have A, B, and C, you're welcome to make that recommendation too. But we felt like so far, let's let the private market offer, and let's just set some standards. And
So as long as they meet the minimum standards of what's in the rule, you're not necessarily concerned about whether the content is pro or anti-cannabis, is what you're saying.
well, I think one of the bottom lines is that in any course, we want it to be evidence-based. Right? So you're gonna find that there will be a lot of content in the coursework. A lot of the evidence out there is warning people about cannabis. We don't know this, we don't know this, we don't know this, right? That's where some of the evidence is. And there's also some evidence that suggests in these limited cases where it's helping. Right?
See, but I think even
So-
right there, that statement, you're qualifying that statement to say there's a bunch of stuff out there that speaks negatively about cannabis. And then there's this small, almost sliver.
No, I didn't say sliver.
I mean, is that not, I mean, I feel like that's a pretty fair characterization. And all I'm saying is,
Yeah,
I'm just trying to get your position, not to paint you into a corner, not to paint you in a bad light, but to just understand. If it's just that they need to meet the requirements of the rule, that's all I'm just trying to understand. That's all my question was aimed at, not whether you all are you're required to gatekeep on how they present the information. I'm just trying to understand better, if they meet the requirements of the rule, that you guys approve if they basically, if there's 4 things that have to be taught
Sure.
on, and they have all 4 of those included, you guys aren't necessarily going through those to determine, whether they're speaking too positively, too negatively, too whatever. It's just, hey, you've got a section on whatever, subpart A requires, therefore we approve the material. We're just trying to better understand, I think, how the material gets approved, because I do believe that I represented fairly what you stated, and I think that's honestly fairly stated in terms of the rest of the conversation that's happened, not only in this meeting from time to time, but everything that we've heard up at the Hill. I have not seen you as much on the Hill as I've seen you in prior years. But the conversation going on right now up at Capitol Hill is whether cannabis should even be legal or not. That's a conversation that was decided in 2018 by the voters of the state of Utah. And to know that we as industry are trying to fight to say, we're happy to present both sides of the argument. I think sometimes it gets a little bit twisted, and we're seen as, because we make money off this, because we chose this as a profession, we ignore the other parts of it. Absolutely unequivocally untrue. We want the truth to be told about cannabis, science-based, evidence-based, all that stuff. Because what we know anecdotally, we think will win out in the end. That may not be true, but we think that will win out in the end. So all we're trying to say is we want to have a fair and balanced presentation of what cannabis is and cannabis isn't. And so my question just was, are you guys doing that type of analysis? If not, no worries.
Yeah, we don't have a position on it. The coursework, as stated in the rule, requires that there be general guidance and recommendations for medical cannabis and history of cannabis, dosing forms, considerations, drug interactions, adverse reactions, contraindications, such as breastfeeding and pregnancy and toxicology. That's what we're looking for. And if there is any provider, any company that would like to create the content, for 5 years, companies have had the opportunity to present and have us review the content, right? So we would love for there to be more options for people to complete it. And if there's more options, you're welcome to share those with us.
I think to put a fine point on it, yes, we look at what's in rule. If it meets the requirements in rule, then that's what binds and gives us authority to say yes or no, this isn't approved. And I will, Rich's point, rule is we are continually looking at rule, evolving rule within our statute. And I think that, if you have suggestions on other things that would fit within statute that could be, added to rule in amendments, I think we would love to hear that. We want to continue to refine this process so that it works for everyone.
And something else is that the providers in Utah have invited board members to take the courses. We can share those links again. So if you want to learn more about the content that's actually taught in the courses, we can help you with that.
Yeah, no, I'd appreciate that. And it's not, it's just, there's a bit of frustration, I think, seeing the way cannabis has been treated during this legislative session. And while we don't expect you all to be pro or anti, we just expect the truth to be told wherever that lands. And it's been hard to listen, not, present company excluded, but it's been hard to listen during this legislative session to hear outright, like, not factual truths be told about cannabis over and over, and to see that now impacting the legislative process in a negative way is really hard. So all I think we're saying is fair and balanced, and I think I hear you guys saying the same. So I think we're speaking the same language. It's been hard. I'm sure a lot of you have heard a lot of the testimony, and it's been hard to swallow.
Just sit there.
Yeah, it's been hard to just sit there and say, all right, we gotta see this thing through. So.
Well, and then, I mean, within the industry itself, specific to Utah, there are several pharmacists that have their masters in medical cannabis and therapeutics. So, I mean, it's obviously, there's a program that's accredited university that discusses medical cannabis in depth. So, I mean, potentially, if they have continuing education material that they've done themselves, that could be add better value. That's something that, I mean, maybe, we can talk offline and see if it's something we can get to kind of get proposed to be added to curriculum. So it's a little bit more informative rather than not subjective, but lost my train of thought. Or whatever. Yeah.
Just evidence-based.
Yes, just evidence-based, yeah. So, okay, any other questions on HB 357? So, again, that was approved through committee today. It does have to go through the House. It's got a long list of bills to get through.
Oh, yeah, through the House.
Through the House, yeah, there's 111 bills ahead of it. So, they're working their way through it. So as soon as it gets through there, then
I would imagine most of the bills at this point will be towards the last.
yes.
Yeah, even though they tried to introduce everything this year a lot
Sooner
than
than
usual, I imagine we cleared the decks
Yeah.
last night session.
We'll see where it goes from there. So, all right, we will go ahead and move on. So we're making great time today. So HB 343, this is one that was also introduced last week in committee, and did get approval. So kind of just real quick on this one, the TLDR version is an odor reduction plan between UDAP and municipalities and counties. So this rule essentially is targeted towards production establishments within industrial zones. So under state law, there's two locations that a production establishment can be located: an agriculture or an industrial. And then that city, county, or municipality has the right to decide which one they will allow them in. And if they are in industrial, this plan essentially states that they need to come up with an operating plan on that, what can identify anything that's not meeting any local ordinance nuisance laws. Odor is the biggest thing on here, and what causes the odor and what they can do to mitigate it. And then it essentially has UDAF provide a report annually to the Medical Cannabis Governance Structure Working Group on a list of 6 items here. So potential standards for measurement of objectionable odors, the feasibility of setting a universal odor control standard, the feasibility of enforcing that standard, the cost that's incurred to comply with that potential odor control standard, interests of other business community members affected by the odor, and other information the department deems relevant. And then the last thing that's on here is, I don't think it's listed in here because there was an amendment, but I do have it. So UDAF will work with the production establishments to monitor, and they'll have to come up with tools or devices to do that. There was an amendment added in that essentially states that as a production establishment, when you're coming up with your operating plan, you as a producer will consult with each county municipality that has a production establishment site within their boundaries regarding potential standards for a maximum amount of objectionable odors emitted by a cannabis production establishment. So that amendment was added before that meeting. And again, I mean, we've heard this many, many times is, as a cannabis business, really, we just want to be treated like every other business. And I think there are aspects of this bill that puts us in line. I mean, there's not many times you do specifically get called out in state statute on a city level. But I think for us, we do our best to be stewards of our community and work with them, and they know where we're at. And cannabis, we didn't get in this knowing that it didn't smell. There is an odor. It's part of a lifestyle. For some, it can be objectionable. For other people, they love it. And
Heard some of these from.
that's true.
I've heard that.
This goes back to the testimony that was said, but I just know, working in my community where we're located, we tried our best to, our community, it was either a farm, because we have a lot of land around us where we're located, or it's gonna be over 90+ homes. And if you're in a farming community, they don't want the homes. So they all appreciate it. I think, again, many people understand the medicinal benefits of cannabis, what it's done to change people's lives. And so as we work through this, I think, yeah, so that's really the bill. Any questions, comments?
I mean, it's probably no surprise, we are the producer that, kind of spurned this bill. I said this when I testified, and I'll say it again. We've spent over $200,000 to this point and are prepared to make even more investment. So we clearly take this seriously. One of the most important parts of the bill is that it does recognize that a zero tolerance policy around cannabis odor is not tenable. So while it does establish a definition for now, at least that definition starts at the property line. We look forward to working with UDAF to see if that is somewhere where the odor can be contained within. But again, we are trying to just be treated like any other business, and the ordinance we're currently subject to, in our opinion, does not do that. And so this bill does move that forward a little bit. It does maintain a good balance with the local control provisions, not allowing cities and towns and municipalities to kind of opt out from having cannabis businesses locate within their jurisdiction, but also understands that cannabis odor is not, a pleasurable thing to many. What we have learned through the process is the closer you are to the facility, it seems to be a little less objectionable. As it floats further away from the facility, the terpenes and everything else gets stripped away, and all that's left is the sulfur. So interestingly, that's why if you're maybe 1.5 miles away or somewhere, I'm not saying exact distance, but if you're further away from the facility, it may be more, objectionable. So we look forward to working with UDAF on this. I mean, we will be the guinea pig, for this, because as far as I know, we're the only cultivator that's in an industrial zone. There are other processors that are.
There are two other growers.
Two other growers, yeah. So, and I'm not sure if they're subject to the same local ordinances or not. So what we're hopeful this will do is eventually lead to a change in local ordinance and come to to some sort of reasonable agreement where we can continue to operate and produce some level of odor, but not, an amount that's objectionable to people living in the community. But this is not just a thing in Utah. This is across the entire country. They're having these things. But as I've said before, we found ways to tolerate other odors in our society. So I'm hopeful that, eventually, stigma will fall away. But we look forward to working with the bill sponsor and with UDAF to come to some sort of more objective standard that's not just a pure zero.
Yeah, I like the language in there. It's reduce odor or mitigate odor, not eliminate odor.
Yeah, and the bill sponsor on the record admitted that a zero tolerance policy is probably not ever achievable. And we know that. Like, I think no matter how much money you put into this, there's going to be some level of odor that is created. In a lot of ways, the odor is part of the medicinal value of the plant. So yeah, but it's a step in the right direction. Even though we're going to be, under the microscope for purposes of it, we welcome it. I mean, we've already spent significant amounts of money to mitigate the issue.
Any other questions, comments? From the board? I do want to spend some time going through the agenda. I mean, obviously our next meeting is in March. The legislative session will be pretty much wrapping up by the time we meet. I think their last day is.
March 7th.
So they'll be done. We'll be meeting the 18th. And one of the things I'd like to see, especially going forward, is there any, what can we do as an advisory board to help kind of grow this program? B, make it so that way, I think the biggest hurdle we've seen is keeping patients within the program. How do we make that? We have had several discussions. I mean, there's lots of things we've tabled in the past. We may bring back to try and see what we can improve. As well as recommendations. I'd like to get us some recommendations to the Center for Medical Cannabis Research on things we'd like to see studied. Give them some topics to see potentially help lead to maybe additional qualifying conditions or different additional doses, dosing and things like that. I know as a board, we did vote on chocolate and that was seen unfavorable by the legislators, but let's have them do a study and see if we can get some science, some evidence-based feedback on the medicinal value in a chocolate dose. And I mean, it may not change their minds today, but it may get that started. So what other thoughts does anyone have?
Did the state-run inventory website make it to the SB 64?
No.
What about the subsidy program?
No, that was in the ombudsman. The website actually was killed in the substitute bill of HB 203.
Between the 3rd and 4th, yeah, okay.
The COA website was removed between the first and the 2nd and 3rd.
Correct.
So.
Well, like JD was saying, I think patient access, the
Okay.
card drives were successful because it's an overwhelming system. It's really complicated. There's not a lot of direction. I know websites have been moved around and changed, but it's still overwhelming for patients. And they want more options as edibles. I think that's why I asked about the website, because I think a lot of patients just want access and want to know what's available. They still can't do that. And it is a feat to have to go through every single dispensary looking for your product. So that's my patient.
Well, I think without having a budget for the board, sometimes it's difficult, right? Because we can make recommendations and then whoever we make that recommendation to, either does or doesn't. So I think in some ways.
Yeah.
But I do agree. I think making recommendations to the Center for Medical Cannabis, research, I think would be good. Look, a lot of what it is going to be in this next year is, and I've said it a few times today, telling the truth about cannabis. So if there's a way our board can do that, or at least recommend those things, that, it would be helpful. And it might also be helpful to be able to call on the Center for Medical Cannabis and say, hey, are you aware, or maybe even the CRRB until it's sunsetted, are you aware of any studies that can combat this, right? Because I could have easily stood up at the meeting last week and said, the gateway drug theory has been dispelled over and over and over again, but I didn't have a study in hand to be able to cite to. And I've read enough of them, in the last several years, so it'd just be nice to have some of that stuff maybe more readily available and on hand. And I think this finds a way that we can collaborate better with the Center for Research, not to ask them to come up with something that is not evidence-based and true, but to say, hey, I've definitely heard on a number of occasions this said, is there any research out there that you could point me in the direction of that I could use to fend it off? Because clearly our own anecdotal experiences are not enough. They're enough for some folks when it's on a certain side of an argument. They can just say all, youth are addicted to cannabis and everyone won't, bat an eye at it. But when we say, no, actually, that's not true, we usually have to provide some form of a study. So I'd love to be able to see some collaboration there. I do have another specific one. I've talked to, Cody's probably aware of it, around final package testing for flower. Something similar that they kind of allow for concentrates, where you can do a bulk test and then apply the cannabinoid and terpene, the potency results to your final package testing. And then once it's truly final packaged, then it would be tested for all adulterants, microbials, all of that stuff. It just allows you to be a little more nimble in your decision making, especially if you have multiple brands. on what flower goes in what brand. It also allows packaging a lot easier. It's a whole lot easier to apply a fact panel to a
Yeah.
flat bag than it is to one that's full of flour. So it would still, the candidates would still all undergo the same testing. It's just a question at what point you could use results, you know,
Yeah.
for maybe a little earlier in the process. So Brandon is likely to come out to our facility. So I don't know if that'll be ready for next month, but certainly hopefully by April, we'll have something on that. So. But otherwise, to me, I think us raising awareness in 2025, you know, would be helpful. So I don't have any specifics today, but I certainly would be prepared, even if we just made it a group agenda item for next month, to come forward with, you know, 2 or 3 ideas each. I could see that being real helpful. More of a working session than
Yeah.
maybe recommendation session.
And well, and that's what March will be. I mean, I was gonna discuss it with in our strategy meeting with Tez and everyone, is I want to just kind of be a work session for all of us to kind of go through ideas. I mean, we do have the ability to have some subcommittees. We have set them up. They haven't really gone anywhere since the day they were set up, but I think it's a good opportunity for us to be more proactive and have this be a working group. And so that way, when we are making proposals, especially getting ready for the summer when the working governance group starts meeting again.
Because we should have a few months in between when the session ends.
Yeah.
When Cody and or DHHS start, you know, if there's any rules they have to make coming out of the session, we will have a couple of months before we see any of those. So
Let's see, most of the bills go into effect on May. They'll have 180 days to get all the rules added.
rules will come late summer.
Yeah.
Early fall.
Yeah. Cody likes to wait till day 179.
There's a possibility you guys have to.
Oh.
Small possibility.
Perfect. Anything else? Yeah.
Yeah, the only other update and Rich, you can correct me if I'm wrong, but the CRRB met recently. We updated the statement on epilepsy as an approved medical use. We reviewed several other articles. And we actually will only be meeting once more, I believe, as a committee prior to it transitioning to the CMCR. So that's something to keep in mind.
Yeah,
So
yeah,
that's on
assuming
the
that
horizon.
bill passes, and that was a provision of 203 that has
Yes.
been moved over to Senate Bill 64.
Mhm.
So we will, we'll be able to share with the board information about that transition.
Yep.
And make sure that's part of the agenda.
Yeah. We did a really in-depth dive on epilepsy recommendations and what the evidence currently supports, and that will be updated on the site.
And more discussion about reducing diversion too. Like we talked about it a lot, but I don't think really came with anything that had any applicable substance about reducing that diversion to either street purchases or traveling out of state.
Can you repeat that? I'm sorry, I couldn't quite hear.
Sorry, just more discussion about reducing diversion.
So like not necessarily diversion of product, but diversion of where people are going to purchase.
Yeah, from like
Sources.
leaving the program to purchase.
I think it goes back to price and options. I think those are major reasons why most patients are.
I just know it comes up a lot.
Yeah, I think it's gonna be a fine dance, because what necessarily will be best for patients might not always be best for the industry, right? We have to find a balance between the two, because a lot of these states that many of these patients are traveling to, their programs are in significant trouble and are backsliding, right? You know, you look at Colorado and some of those places. So I think if you look at the numbers, I mean, even the numbers that DHHS presented or UDAF presented, pricing has come down, but still, when you compare it to certain, especially really, mature markets, yeah, it's definitely not there. But I agree with Nanette, that's probably the number one consideration as to why. Now, I do think also form factors, right?
Mhm.
Like we'd be
Yeah.
lying to ourselves if we said, and I'm not advocating for smokable flower, but I'm saying we'd be lying to ourselves if we didn't think that the pre-roll market in these other states, or other smokables is not having a significant impact on patients, decision making as well. And not just those, right? Say, we don't allow chocolates here, right? Well, if someone wants chocolates, we don't allow drinks here unless they're, a liquid suspension in 30 milliliters, right? So I think we have to be mindful of those things too. And it goes back to honestly what I've been saying for a while now. If we don't make significant changes or certain changes to the medical cannabis program, we will continue to see that trend, but what we will probably also see is a ballot initiative at some point for adult use, right? That's usually what happens. Once the medical program doesn't work, that's usually what you see. So I think I would absolutely be in favor of any changes that are going to keep Utahns in Utah consuming, Utah cannabis. But it also is incumbent upon those that are already in, the producers that are already in, to continue to innovate and observe best practices and improve the medicine that they're producing, because that's clearly a part of the equation as well. Rich, that 55% that you reported on earlier today, do you know how that compared to the month of December? Is it about the same? Or is it higher?
I have to do the math. I haven't done it yet, but I could share that.
And maybe
with
that's
you
just something,
before.
I think just each meeting, when you do your statistics, I do think that would be useful.
We can look at prior months.
Yeah,
That's easy.
even if we just don't like quarter over quarter, once we get enough quarters behind us,
Yes.
or even month over month to just start with, to know if there are any impacts from a month to month basis or even quarter over quarter basis to that purchasing trend. Because while it's on a monthly basis, I think the numbers of people that are purchasing in the program, maybe not on a monthly basis, but they were more healthy. They were more healthy numbers when you all reported, on them. But clearly on a month to month basis, we're a little more than half of the card carrying folks. So.
Right, I think the smokables would be a huge market because I think it's overwhelming to get into. You have to buy a lot of things to be able to vaporize flowers. It's very expensive. It eliminates that. I think patients that are older, or sick, their dexterity isn't great, so they can't even have that option to smoke them if they wanted to. So I think pre-rolls would be a great place that would allow patients to have some options, but yeah.
I'll put that for the next agenda item. Good luck with that one.
I heard the Cannabis Research Review Board talking about I think it was a couple months ago, about the elderly patients, and that was who was using more, I think. I don't even
At the symposium, there was a
Yeah.
discussion
Was that what it
from one
was?
of the presenters about age-related differences
Mhm.
in use.
Yeah.
But I think it's gonna be I don't think a recommendation for smoking anything will ever be supported. There's just too many inherent risks associated with smoking.
Yeah, and to me, I bring it up not more to say
Good
whether
question.
I'm an advocate or not. I'll
Yeah.
leave that for another discussion, but what I am saying is I think we should be mindful that that's one of the factors
Absolutely.
that people may not be
Absolutely.
purchasing in the Utah, in the Utah market. So just things to, I think, be mindful of, not necessarily to say we advocate for them,
Yep.
but just more of a discussion, point
Absolutely.
than anything.
And Matt, if I could add, one thing I think I mentioned it earlier, but on the horizon is a market analysis that Utah Department of Ag must do. And what we've decided to do with Ag's lead is to coordinate with the University of Utah Center for Medical Cannabis Research on a survey of 3 different types of patients. Those in the program, those who were in the program, no longer in the program, why they chose not to get a card anymore. And then those that have never joined the program and have a qualifying condition, what are factors that have impacted their decision? Do they even know about the medical cannabis program? Right. And then also to focus on the medical providers as well, not just the patients, and to understand their barriers, but the medical provider barriers as well. So as we get more into detail on planning those surveys and those ways of learning more about the audiences that we're here to serve, we can share those results with you and with other stakeholders, so we can all learn together about what these groups are telling us. It always depends on the response rate, but what we're wanting to make sure we can all learn together and get the best response rate possible to the survey, so we can move forward and understand the market the best.
And I would say that's got to be the most holistic view that's been taken yet to date in terms of any of the surveys. So I would applaud that, right? We're finally going to get to all the different groups, you know what I mean, that are involved. So I
Yeah.
applaud it and I look forward to, you know, obviously the devil's in the details. It'd be interesting to know what all the survey questions are and everything, but those main groups that you're talking about, I think will give us a much better view of,
Yes.
of what the program is or it isn't. So I applaud the analysis.
Yeah, so we'll be sharing more later on, but that's on the horizon in 2025.
Cody, do you know, has that market analysis started? Is it still in waiting to finalize the dot the i's and cross the t's?
We've got a contract that's on its last leg of getting signed with the University of Utah.
Okay.
Once that's signed, that they're already planning. But
Okay.
it's a requirement that we of course have the contract that covers how much it's going to cost and everything for them to do this, but.
And then
Yeah.
that has to be presented by what, November? You present that to the legislature by November? Is that what will happen with that?
I think that one.
Anytime?
Yeah,
Okay,
November one's just the report.
like just the market report? Okay. Okay, good.
All right, anything else people would like to discuss in the next meeting? This will help our strategy meeting. Some topics. I mean, and again, if there is something that we feel we kind of want to discuss, Trevor may reach out to you or someone else if there's any input you would like to add, to get added to some of these discussions.
I would say if there's any recommendation from the board for other qualifying conditions that you'd like researched by the center,
Sleep, anxiety, depression.
well, yeah,
Give you 3 of them right there.
Yeah. I think that would be valuable.
And that might be one that we can add. I mean, like I said, I've been wanting to get something formal out there for quite a while on these qualifying conditions, get them revisited. I think I joked at the beginning of the legislative session, I joked and said, let's just get rid of them, but
Well, I mean,
I mean, I
you
think
know,
it's.
you know the position that I've taken, that
No.
we should provide a catch-all provision.
Yeah.
And it should allow doctors to be doctors, right? I'm not aware of any other medical condition there where there's 16. You know, and I understand some of that is based upon the fact that the science and whatever hasn't caught up, or at least, you know, some folks feel like it hasn't caught up. But it just, it's also hard too when patients are saying like, well, yeah, I went and, talked to I saw a QMP, or I met a QMP and I said this condition and I said this condition. Then I said this condition, they're like, oh, you know what I mean? Like, I just feel like with, while it's not without its, potential ills, it's not killing anything, right? And I think we should allow doctors to be doctors, and I hope that's the direction we'll trend in. And I think that's why you've seen not just a state like Oklahoma, but a state like New York and some of these other states either drop their qualifying condition list completely and or provide some sort of catch-all provision that says, and look, you may not have to do it for youth patients, right? You may not even do it for that 18 to 21 segment, but 21 and above, I feel like we let a lot of people consume a lot of things after age 21 that we probably shouldn't, or we should think more about. And I feel like cannabis should get treated similarly. So to me, if we have to go the route of it getting more individual conditions approved, great. But if not, I think the time would be, should be well taken that should let doctors be doctors. And now if we're going to open it up and not require QMP registration, it seems like that's the next kind of logical step in the progression.
No, I'll get that added in there. Touch base. So, good. Anything else? Chris, do you have anything you want to add?
Not at this time.
Okay. Perfect. Well, with that, we've set records. So, that really covers everything for today. I mean, again, stay tuned to the legislative changes. Those bills are still moving through. Still a couple more in committee, and then there's a couple that are just moving through either the House or the Senate for votes, and they're still changing daily. So, I mean, if you do pay attention to those bills and track them, amendments get added an hour before they're going to.
Down the right-hand side of
Yeah.
the bill, if you're on, is where you can find all of the
Substitutes and amendments.
substitutes and everything. And the substitute hasn't been moved or an amendment hasn't been adopted or anything, they will appear on the right-hand side and you'll have to click into them to see what they are. They don't always display. They display the most current kind of adopted version of it, but not always, amendments or substitutes that have not been moved yet.
Okay. Well, with that, I look for a motion to
Move to adjourn.
motion seconded and approved, and it's unanimous. So thank you very much, everyone.
So with sleep, they've at least looked at it as a secondary